Okay. All right. Next page. On this page, because I just gave you little reminders. On this page, because many of what we do in pediatrics is miniature adults, put COMG packet. It's all there already, isn't it? It's all your shocks are already there, right? Your anaphylactic shock is in your OMG packet. All of that is there. Turn the page. Meningitis. For this patient, I want you to know that if we give you this triad, you had to know, and I'm going to make a triangle up here for you guys. This triangle or triad for meningitis, high-grade fever, severe headache, and what's the number one? Rigidity. Now, the fun part about this is it's completely covered in your neuro lecture that's in your videos. So I'm going to give you additional child issues, but this is nicely covered. And you have the same exact handout in your neuro packet. So here's what I want to give you. Number one, I want you to know it will kill you in 24 hours. It will kill you within 24 hours. Number two, I want you to remember that bacterial is the deadly one. Viral, we send you home. But both look exactly alike. Bacterial will kill you. It's the deadly one within 24 hours. Viral, we send you home. Bacterial is droplet. Viral is contact. Bacterial meningitis is droplet. Viral is contact. There are 3 signs that patients will have. They will have a positive Babinski, and when is that normal? Under what age? 2. Good. They'll have a positive Brudzinski, and they will have a positive Cushing'S. So you got all 3. The baby has a bulging fontanelle. The baby has a bulging fontanelle. Somebody said that at toe-to-toe, but it wasn't right.
The girl who did it.
What was she doing when she said bulging fontanelle? What disease was she doing?
She was talking about the flu.
Oh yeah, the flu ain't no bulging fontanelle. It was so funny. Okay, so we make mistakes, but the little girl at toe-to-toe said bulging fontanelle for the flu. Not so much. It's bulging for this. Okay? High-pitched shrill cry for a baby. High-pitched shrill cry for a baby. Irritability. Vomiting. Poor feeding. Okay. Now, something else that looks a lot like this is West Nile virus with encephalitis. West Nile virus with encephalitis. So far, so good? Okay, now West Nile, who the hell is West Nile? Who is that? That is getting stung by mosquitoes that fed off of dead birds. Don't forget the dead bird part. Mosquitoes that fed off of dead birds vector-borne precautions for that. Remember, this child needs seizure precautions, whoever it is, encephalitis, meningitis, won't care. Seizure precautions. They are no longer contagious after antibiotics for 24 hours, but they do go in a private room before that. So ordinarily they go in a private room, right? And they are no longer contagious after 24 hours. So after 24 hours you can roommate them. But you start them off in a private room. No longer contagious after 24 hours of antibiotics. You really want to know that. Meningitis vaccine is in junior high, 11 to 12 years old, with a booster at 16. The number one age is 18 for this. Treat this with penicillin G. Treat the patient with penicillin G and close contacts with rifampin. The next thing I want you to write on this page, because it has exactly the same signs and symptoms, is Reye'S syndrome. It's right here. So what do you got? You got meningitis, encephalitis, and Reye'S syndrome, all the same symptoms. Reye'S syndrome, R-E-Y, keep it on the page. Reye'S syndrome, R-E-Y-E-S. Make sure you know exactly what I'm saying on this. This is a viral infection that was treated with aspirin. This child had a viral infection treated with aspirin. And don't be thinking you're going to see chicken pox. No, you're not. You're going to see flu. They know you know chicken pox. It's going to be flu. So, you know, some people be like, what is chicken pox? Flu is a virus. So just stick with viral infection treated with aspirin, the fever treated with aspirin. No aspirin in children under 18. Remember that these children, whether it's meningitis or Reye'S syndrome or encephalitis, may benefit from mannitol and hypertonic solutions. Hypertonic IV solutions. Mannitol and hypertonic IV solutions. There is no cure, but it's got a good prognosis if you catch them early. People used to die from this every day, but not anymore. When I was a kid, they died from it every day. We always heard it on the news. Every single day, all day. People were dying because everybody had a high-grade fever with chickenpox and everybody gave baby aspirin. That's all we had. We had Tylenol and Motrin. That's all we gave was aspirin. Okay. This is not going to be a page in here, so turn to the next page and throw it at the bottom because it's short and sweet. At the very bottom of the very next page, underneath the little teeny tiny words, put nephroblastoma. Nephroblastoma, and in big letters, put Wilm'S tumor, because that's what it is. Wilm'S tumor. So this is usually a toddler. It is cancer of the kidney. They will need surgery, chemo, and radiation. Good prognosis. Do not palpate, tickle, or massage, or you'll spread it throughout the entire body. Don't tickle, palpate, or massage, or you'll spread it throughout the entire body. The precursor is hypospadias. That's the precursor. So this baby that has Wilm'S tumor was born with a hypospadias. Okay, on the same page, go up a little bit, put pyloric stenosis. What's the classic hallmark? Projectile vomiting. So if it's projectile vomiting, what kind of acid-base imbalance do you have?
Metabolic acidosis.
Metabolic
Metabolic alkalosis. I told you diarrhea, if it comes out your ass, it's acidosis. If it come out the other end, it's alkalosis. Okay, so separate them two. Diarrhea comes out your ass, it's acidosis. Come out the other end, it's alkalosis. Okay, so metabolic alkalosis, we have projectile vomiting, we have an olive-shaped mass in the abdomen on the right side of the umbilicus. The baby is constantly hungry. They're usually between 3 to 5 weeks old. Their potassium is low. The vomiting is green. They are extremely dehydrated and they need surgery. Very often misdiagnosed as Gerd. If you remember, that's what happened to Miss Ralston's baby. She passed her test, she was here, she used to sit right there with y'all. Kimberly Ralston, her baby had this. And she brought him to see me, Okay, anyway, Gerd. So that's a separate category, write Gerd on that paper. Gerd is really easy, because you already know what it is. Gastroesophageal reflux disorder. This baby is born, and unfortunately, Gerd is not seen first in adults. It's seen first in a baby, because they can code. This mother needs to be taught CPR. Gerd in a baby can kill them. This mother and father need to be taught CPR. It is an immature lower esophageal segment. So the lower esophageal segment is immature. We see it in premature babies and sometimes babies who were induced before they were ready to come. That's why I don't believe in inductions. So very immature lower esophageal sphincter or segment. Even though you think your baby was ready, you force the issue. Babies come when they're done. God knows what he's doing. Stop trying to fuck with it. Okay? All right, now this baby again can code. Okay, so the parents need CPR. They may need an apnea monitor. They're at very high risk for aspiration. Decrease the amount of time they're in a car seat, because when they're in the car seat, they do this. They're all scrunched up in the car seat. They need to be like sitting upright. And so if you carry them on you, that's the best position. If you carry them on you, that's the best position. They need to sit right up, especially after eating, for 30 minutes at least. The same treatment for a grown-up, we do it with a baby. Avoid tight clothes. We'll probably give them some Mylanta. Okay. Now, the actual page that you're on is tracheoesophageal fistula. And this patient, you can see the 3 C's. Add a D for drooling. So you see the 3 C's are choking, coughing, cyanosis, add a D for drooling. This is a patient who, if you feed them before you figured it out, you just fed their lungs and killed them. So when I delivered this baby, and I have delivered this baby, number one, you had to realize that during the prenatal period, This patient of mine had polyhydramnios. What does that mean? Too much amniotic fluid, polyhydramnios, because the baby couldn't swallow. So it's just collecting fluid. Prenatal history includes polyhydramnios. Remember, this is a tunnel between the lungs and the esophagus, which is crazy. So the GI system is connected to the respiratory system. So if you feed them, you fed the lungs and killed them. So when this mother, when she had her ultrasound, it didn't show, because it's hard to show, right? So again, she had polyhydramnios. She was actually one of my nurses. And so she had polyhydramnios. When I went to go deliver the baby, it did this. And wouldn't stop. Because choking, coughing, cyanosis. Turned blue. I said, okay, we got a wet one. That's how we, under the table, say suction. So, okay, we got a wet one. And it just did not stop the coughing and the choking and the spitting and the going. And I was like, okay, you better not feed that one. But anyway, it's a great kid. Got surgery. She's cute as button. Very good prognosis. Very good prognosis. As long as your crazy behind don't feed them. Now, what you did have to know is that the saliva was bubbly and frothy. So frothy saliva, they're at risk for apnea. What does apnea mean? Forgetting to breathe, yeah. So bubbly, frothy saliva, frothy sputum might be something you see, but they're, because their lungs and their GI is together. So they are in PO. The head of the bed is up. We make sure we have suction available and O2. And they need a G tube. Don't make a mistake and say NG, because where you put the NG at? Down their damn lungs. You've got to do G tube, right? Gastric tube and warm up their feeds. Don't forget that part. Warm up their feeds. So the G tube